This will be our presentation on the diseases of the external ear. I'm Dr. Amir Gorgey, a lecturer at the Department of the ENT in the Alexandria University. These are the intended learning outcomes for this topic. As you see, there are many of them because we are discussing many short topics. As we remember from the anatomy, the external ear consists of the auricle, the external auditory canal, which has a cartilaginous part and a bony part. The auricle, it consists of several depressions and elevations, and they have many names of their own. So as what we have to remember, the tragus, this cartilaginous protrusion in front of the ear canal, the concha, the part behind the ear canal, and the helix, which is the outer margin of the auricle, and the ear lobule, the fatty lower part of the auricle. As we remember, the canal has two main parts, the outer 1/3, which is cartilaginous part, which has a hair follicle, sebaceous gland, and ceruminous glands. The medial 2/3, the bony part, it has thin skin overlying the osseous canal, and it doesn't have these skin appendages. Diseases of the external ear, there are congenital and acquired diseases. Congenital diseases, we have some important diseases. One of them is microtia with or without canal atresia. Atresia means obstruction of the canal or absence of lumen. We have preauricular sinus. We have less important but common things like the bat ear deformity. For the microtia, literally, it means a small ear. Micro means small, and otia, it means ear, so it means small ear. So microtia varies in grades from simply an auricle that is smaller than normal with very few deformities, and progressing up till complete absence of the auricle. And with any of these, we may have a normal canal or atretic external auditory canal. So we have two main considerations here, the external appearance and the hearing, because if the canal is atretic, there is conductive hearing loss. So what we have to consider when treating such cases, we have to consider associated anomalies, whether in the body as a whole or within the ear. If we have atresia of the canal, we have to do a CT scan to see whether the middle ear cavity is normal or deformed. We need to evaluate the ossicles. We need to evaluate the inner ear anatomically. One other important thing to consider is the hearing. So for these infants, we do ABR to assess for the hearing, to see whether the child has associated problems with the hearing, the extent of hearing loss or the amount of hearing loss present, and of course unilaterality or bilaterality of the disease. If the child has a unilateral problem, then he can hear well with the other ear, so he can depend on the other ear to develop his own spoken language without much delay. But if he has bilateral problem, then there will be bilateral hearing loss, which will have an effect on the understanding of sounds, of speech, and then the development of spoken speech later on. So what do we have to do? We have two issues to address, the hearing and the cosmetic deformity. As for the hearing, if the person has a normal other ear, so we are not in a hurry, but if he has bilateral problem, then we need to address this conductive hearing loss fast. So one thing to do in the earlier ages is to use a bone conduction hearing aid. This bone conduction hearing aid will simply take the sound, transmit it to the bones of the skull, which will directly transmit it to the inner ear, thus bypassing the obstruction in the conduction of sound. So here, for a young child, we use a bone conduction hearing aid as a soft band. We have a soft band like what the girls are wearing normally on their heads, but it has hearing aids on both sides, and it's pressing on the skin, thus conducting the sound to the bone. At older ages with more growth of the skull bone, we can use a bone anchored hearing aid. That means we are fixing metallic screws to the bone of the skull, and to these metallic screws are attached hearing aids that will transmit the sound to these screws and then to the bones of the skull and directly to the inner ear. As for the cosmetic repair of the auricular deformity, we usually do it by the onset of school age, around 6 years, 7 years. At this age, the child will face other colleagues. He will be subjected to develop psychological problems due to worry about his shape or due to repeated bullying. So we do the repair before then, and we have two ways to do the repair. One of them is to take costal cartilage and shape it in the shape of an auricle, and this will be implanted under the skin in the position of the auricle. Typically, this is a stage procedure. It takes 2 stages or more to finalize or to reach the final shape. The other way to do it is to implant metallic screws in the place of the auricle and to place prosthetic auricle in its place, just matching the shape of the other auricle if the other auricle is normal, and matching the color of the skin of this child. More minor congenital anomalies like the bat ear. Here we see a protruded ear with absence of some of the ridges. So this is corrected by a procedure called otoplasty if the patient is willing for a cosmetic repair. Another common congenital anomaly is the preauricular sinus. This preauricular sinus is present in front of the root of the helix, as we see, and it has branching tracts that go under the skin, reaching to the perichondrium or to the periosteum. For many people, this preauricular sinus will cause no problems. They can live all their lives without having any trouble with it, so we advise them to just keep it, no problems. But if the patient is developing repeated inflammation or abscess formation in these tracts, so then we offer him a surgical treatment to remove the preauricular sinus and the branching tracts. How do we do it? We just inject a colored dye. Here we inject methylene blue through the sinus opening. This should go into all the branching tracts under the skin and stain them in blue. And we do an elliptical skin incision, as we see these dotted lines around the sinus opening. And we go on dissecting the sinus together with all the branching tracts that are stained in blue with the dye, and we need to really excise all the tracts to help prevent recurrence of this problem. As for the traumatic conditions, the auricle as part of the body can sustain any type of trauma, whether cut wounds, contused wounds, burns, frostbites, and for these but we have special considerations related to the hematoma of the auricle. So we will discuss auricular hematoma in more detail. The hematoma is collection of blood in extravascular space, as we know, and for here we mean the extravascular space, the space between the cartilage and the perichondrium of the auricle. As we know, the cartilage has perichondrium on the medial side and the lateral side, and as we know from the histology, the cartilage takes its oxygen supply and nutrition from the overlying perichondrium because the cartilage is avascular. So hematoma can be on one face of the cartilage on one side, or if the cartilage is broken, it can be on both sides, and typically it happens as a result of blunt trauma to the auricle. So what do we do to hematoma? We have to treat it in two-step procedure. First step is to evacuate the hematoma, and second is to apply pressure on the site of hematoma. The pressure will make the cartilage and perichondrium in good contact together to prevent recollection of blood or serous fluid in this space. For the evacuation of hematoma, we can just aspirate it with a syringe and needle if it is still fluid. If the blood is clotting, then we need to incise and squeeze out the clotted blood outside of the cavity. So after we evacuate the blood, we need to apply pressure. So here, for the application of pressure, it's not a simple thing for the auricle because it has many ridges and depressions, and again it has a medial and lateral part, and it's hanging in the air. So for proper pressure, we need to put something that fits to the site of hematoma and transfix the auricle with stitches to keep this compressing material in place. As we see in the picture here, we are using gauze or cotton or dental rolls. We are stitching them to the auricle. Another way we are doing this is to put plastic buttons like the ones we use for the clothes or for the white coats. So we put them on the medial and lateral aspect of the auricle, and we stitch them together with sutures that go through and through, transfixing the auricle. And we keep this pressure in place for 1 week to help prevent recurrence of the hematoma. So what are the possible complications of the hematoma? If it gets infected, it may turn into auricular abscess. Cartilage may become necrosed because the hematoma is depriving the cartilage from the oxygen and blood supply and nutrition supply to it. And all of these, whether there is an abscess or whether the cartilage is necrosed because of the hematoma, or whether the hematoma becomes fibrosed and organized, we will end up with deformity of the auricle. This we call collectively cauliflower ear deformity. As we see here in this picture, this is one of the known people involved in combat sports. So with repeated trauma, you may develop this cauliflower ear deformity. Another very common incidence or occurrence in the ear is foreign body inside the external auditory canal. This is mainly a disease of young children. However, we can see them in adults where accidentally foreign bodies are left inside. So foreign bodies can be of all shapes and sizes. As we see here, you can have it as a sphere or as a polygonal foreign body. Typically, it gets impacted in the isthmus of the canal. This is the junction of the bony part and cartilaginous part of the canal. And it can be, of course, of various materials. So how to manage the foreign body? Of course, foreign bodies need to be removed. So when we are having a foreign body made of a soft material like a cotton, a tissue paper, or paper, then we can hold it with a crocodile forceps and pull it out of the ear canal. If the foreign body is of a material that is more firm like plastic or metal, then we have to bypass the widest part of the foreign body and pull it out using a hook or a curette. Another way to remove foreign body is to do an ear wash. If the foreign body is small and not impacted, the principle is that for the ear wash, the water will run to the medial part of the canal and then run out, taking in its way out whatever that is in the canal. It's used for the small foreign bodies, for the earwax, or for the fungal debris, as we will see later. What are the special considerations related to removal of foreign body? First of all, children. Of course, most of the cases are children, and if the child is not steady, if the foreign body is deep in the canal, if the parents are anxious, and these things are extremely common, so we need to do it under general anesthesia in the operation room. General anesthesia will give us many advantages. First, the child is steady, he is not moving, the parents are waiting outside, you don't need to deal with their anxiety, and then you have proper material. Typically you have an operating microscope, proper instrumentation, then you can see well and take the foreign body safely and without causing any problems. Living foreign bodies such as insects, it's again one special consideration because the insect is living, so if it's moving inside the ear canal and touching the outer surface of the tympanic membrane, it will cause much discomfort to the patient. He will perceive it as intense pain and noise inside his ear. He will describe it as a helicopter inside his ear because you have an insect with 6 legs or a spider with 8 legs running on the surface of tympanic membrane. So this is perceived as loud sound and as pain. For this, we need first of all to kill that insect, and this can be done easily by applying 1 drop of alcohol or any oily drops in the canal just to drown the insect. And when the insect is dead, you just converted this acute emergency into a cold case that can be managed later at any time. One more special consideration is these batteries that are available with the children's toys. So these are more and more available and more common nowadays. Children are putting them into their ear canal. These batteries can release chemical materials that will cause erosion of the skin or erosion of tympanic membrane or other structures in the middle ear. So these need to be taken out very quickly. So whenever you are faced with such a condition, it's an emergency. You need either to remove it or to refer it quickly to where it can be removed. Another special consideration is foreign bodies of plant origin, seeds or things like them. You should not do ear wash, because if you do ear wash and the foreign body is not coming out, the water will cause this plant origin foreign body to swell and become more and more impacted and more difficult to extract. So what are the complications that can happen during foreign body removal? First of them is injury to the external auditory canal. It is not a serious complication, however, it bleeds a lot and it can cause the patient to become more nervous, the parents to become more nervous if he is a child, and it will obscure your vision trying to take out the foreign body, so it will complicate your procedure. Tympanic membrane perforation is a more serious complication, of course, if you are holding a plastic foreign body. If you try taking a plastic foreign body with a forceps, it will slip inside, and as you continue chasing it in the ear canal, you may perforate the tympanic membrane. Of course, if you continue further to take the foreign body out when the tympanic membrane is perforated, you can cause disconnection of the ossicles. This is a less common complication, however, it's more serious. And with disconnection of the auricle, we have witnessed cases where the tympanic segment of the facial nerve was dehiscent, so disconnected ossicle just hit the facial nerve, causing facial paralysis. Even we have seen cases where the disconnection led to disconnection of the stapes from the oval window, causing sensory neural hearing loss. So the take-home message here, if you have a foreign body and if the patient is irritable, if the child is irritable, if you don't have proper instrumentation, if you don't have proper way to visualize the external auditory canal and tympanic membrane and the foreign body, so it's safer and better to refer the child to where it can be done under proper settings. For the inflammatory diseases, auricular perichondritis is the inflammation of the perichondrium of the auricle. Typically, it's caused by injuries that penetrate through the skin and reach to the perichondrium. May happen with open wounds, may happen with insect bites, but more commonly we see it with piercings of the auricle going through the perichondrium and cartilage. Here it manifests by edema and inflammation of the ear. The auricle is red, edematous, and the patient complains of pain, of course. Clinically, when you examine, you will find edematous auricle with blunting of the landmarks of the auricle. It's red in color, erythematous, and if you touch it, it's tender. So the problem with this perichondritis is that it can cause necrosis of the cartilage, it can lead to abscess formation, it can lead to cauliflower ear deformity. So to treat it, we need to apply antibiotics. Typically, the organism here is Pseudomonas aeruginosa, so we need to give antibiotics that should cover the Pseudomonas. And in case of abscess collection, proper drainage of the abscess and repeated irrigation of the abscess cavity with antibiotic will help minimize the complications. Of course, if not treated well, or even sometimes after treatment, it may lead to cauliflower ear deformity, as we have seen earlier. For the inflammation of the external canal, we call it external otitis. Some of them are infectious, like bacterial, fungal, or viral, and some are reactive, related to non-infectious causes. For the bacterial infections and for the fungal infections, we have similar predisposing factors: hot weather, humidity, sweating, manipulations of the auricle, people with immune deficiency, people with skin allergies, and people with chronic ear discharge, as people with chronic otitis media. So as we see here, the hot weather, humidity, and sweating are very common conditions occurring in summer if you are living in Egypt or in a country with similar weather. Manipulation, it removes the protective layer of wax from the canal. It can lead to injuries to the skin, facilitating the penetration of bacterial infection. So first type of external otitis, of bacterial external otitis, is localized external otitis. It refers to the furunculosis. As we know, furunculosis is inflammation of the hair follicle, typically with Staphylococcus aureus. It is similar to furunculosis that can happen in any part of the body. However, the symptoms here are more severe because it develops in a limited space. In this limited space, the skin is very closely adherent to the cartilage, so any movement of the auricle, if the patient touches his ear or sleeps on that side, he will perceive severe pain. If this furuncle will rupture, there will be scanty purulent discharge. So clinically, what we see this swelling in the outer part of the ear canal, as we see, and the hair around it means it's in the outer part of the ear canal. We can see a pointing of pus if there is pus formation inside, or even if the furuncle is rupturing, we will see scanty purulent discharge. There will be tenderness. How do we elicit tenderness for the auricle? Either we press softly on the tragus, or we try to hold the auricle and pull it backwards or pull it in any direction. The patient will not tolerate this. So this is the difference between tenderness and pain. The pain is what the patient complains of, and tenderness is the patient perceiving pain when you are touching this involved region. So what can we do for this patient? We need to give antibiotics for such condition. It's better to give systemic antibiotics that are effective against Staphylococcus aureus. We need to give very good analgesia because the patient is complaining of significant pain. If this furuncle is causing severe edema or obstruction of the ear canal, we can put an ear pack with antibiotics and corticosteroids just to help minimize the edema and fasten the recovery of this inflammation. The other type of external otitis is the diffuse external otitis. So as we see here in the picture, it's diffuse inflammation of the canal skin. This can involve both parts of the canal, the outer part and the inner part. The patient here complains of pain. However, the pain is not severe as in the localized type, so he is complaining of discomfort or soreness or burning sensation. And when we examine, we find diffuse hyperemia of the external auditory canal. We may find scanty discharge or debris. From this debris is formed of the discharge, the exfoliated skin, the wax in the canal. So this is collectively causing some debris inside the ear canal. How to treat it? Of course, we need to address the predisposing factor. We need to do repeated oral toilet. Oral toilet means we are cleaning the debris inside the canal repeatedly, either by suction or by mopping. We apply topical treatment, topical antibiotics with steroids in the form of ear drops. And again, we cannot emphasize more on the treatment of predisposing factors to prevent recurrence and to guarantee rapid recovery. The third type of bacterial external otitis, it is called malignant external otitis. Malignant is not the correct name for the condition, but it is the common name we are using it. It is called necrotizing external otitis or skull-base osteomyelitis. In this condition, the infection will spread from the external auditory canal into the bone of the skull base. So it is a serious condition that can be potentially fatal for the patient. Why? Because of the possibility of spread to intracranial structure, and it can also involve cranial nerve palsies. It doesn't happen typically in immunocompetent patients. Typically we see it in immunocompromised patients. More commonly those with uncontrolled diabetes or with long-standing diabetes, patients with renal failure, patients with HIV infection, with hematologic malignancies or immune deficiency diseases, or patients receiving chemotherapy. All of these have limited immunity. So when they are immunocompromised, they are liable to develop such a condition. The causative organism here is usually Pseudomonas aeruginosa. What is the presentation? The patient will come complaining of pain, but it's different from that of the typical external otitis. Here the pain is of a more chronic course, so he can come to you complaining of a pain that can be here for that has been here for several weeks or several months. So he will say, in the beginning I was having pain that was more at night, then the pain became more persistent, it's now all the day, and by time it may increase in severity, becoming disabling. So the patient can say, I cannot sleep, I cannot do any activity in life, just I'm feeling the pain all the time. So pain is the hallmark of this condition. Ear discharge may be there. Symptoms related to cranial nerve palsies, because this disease will cause osteomyelitis of the skull base, and as we know, most of the cranial nerve exits the skull through foramina in the skull base. So whenever the inflammation reaches to one of these foramina, it involves the corresponding nerve getting out of this foramen. So the patient may come with facial nerve palsy, it may come with lower cranial nerve palsies. Even if it spreads anteromedially, it can cause palsies in the nerves moving the eye. Hearing loss can happen if the lesion is obstructing the ear canal, or if there is extension to the middle ear, or even if there is extension to the inner ear. So what do we see clinically when we examine the patient? We see granulation tissue. Typically this granulation tissue is coming out from the floor of the ear canal, and it's there at the junction of the cartilaginous part and bony part. So typically when we examine the canal, we found this granulation coming from the inferior aspect, midway between cartilaginous and bony part. We find discharge. This discharge is typically purulent. Cranial nerve pulses may be there, and of course, if there is any intracranial spread or any meningitis, we will find the corresponding signs to these problems. The organism, as we said, is Pseudomonas aeruginosa. So if we take a swab from the ear canal, we have to send it for culture and sensitivity to verify for the organism and for its antibiotic sensitivity. So what do we do to confirm the diagnosis? When we have this granulation coming out of the ear canal, we need to take a biopsy out of this granulation just to help differentiate it from tumors coming from the skin of the external auditory canal. One more thing we can do is CT scans. CT scans will show either erosion of the bone, it will show the extent of bone involvement. For more details on the intracranial involvement or soft tissue involvement, we can do magnetic resonance imaging. And then one other test we can do is isotope scanning. This we are giving radioisotopes. These radioisotopes will concentrate in the sites of inflammation, whether in one of them, this technetium 99 will concentrate into the bone, the gallium 67 will concentrate into the white blood cells in the region of inflammation. However, these tests are expensive and they are not available everywhere, so we are doing them for selected cases, not for every case. The lines of treatment, Most important is to control the causative factor. If the patient is diabetic, we need to do strict control of his glycemic state. We need to address the other complications of diabetes again, if any. Earlier in treatment, we can put the patient in the hospital. He may be hospitalized for a few days just to help adjust his blood sugar and to initiate the antibiotic treatment. For the systemic antibiotics, typically we start with a combination of 2 or more antibiotics until the patient starts to improve, and then we can continue with a single antibiotic for a longer duration that can take up to 3 to 6 months. Typically, these antibiotics should cover Pseudomonas. So we take the swab, we start the antibiotics, and then we modify the antibiotic treatment according to the culture and sensitivity results. For the antibiotics, we start, as I said, with parenteral antibiotics in combination, and for oral antibiotics, we typically use ciprofloxacin. It is the most common or the only available antibiotic in oral form that is effective against the Pseudomonas. So typically, the patient will run on the ciprofloxacin for 3 to 6 months. We can follow the patient with the degree of pain, whether the pain is improving or not. We can follow with erythrocyte sedimentation rate. If it's improving, that means the patient's condition is improving gradually. We can do debridement of the granulation tissue in the ear canal. Every few days, you can ask the patient to come to the clinic, remove the granulation from the floor of the ear canal, remove the discharge, and of course, when we remove the granulation initially, we should send it for biopsy to rule out tumors. And hyperbaric oxygen therapy is one line of treatment that can help improve the immunity and improve the oxygenation of the tissue in this involved region. For some patients, it can lead to more rapid improvement of this condition. However, in many patients, this condition is severe. It takes long time to improve, and for many of them, it can recur again, and for some of them, it can turn out to be fatal. For the fungal exotitis, it is called otomycosis. Again, oto, it's ear. Mycosis is fungal infection. Predisposing factors similar to bacterial infections are mainly the warm weather and humidity. So if the patient lives in a humid area, if he's sweating a lot, if he's using water a lot to clean his ear, that makes him more prone to develop fungal infection. As we see here, the fungal elements, we can see the fungal hyphae or the fungal spores here, and it's in some kind of like a paste filling the ear canal. We call it a wet newspaper-like appearance because it's black and white and it's shapeless. It's filling the ear canal. It's moist. So what does the patient complain of? The patient mainly complains of itching. So the fungus causes no pain. It causes itching. If the fungal debris are filling the ear canal, it causes hearing loss because it blocks the sound conduction to the tympanic membrane and to the middle ear. If the patient starts complaining of pain with fungal infection, that means he is developing a secondary bacterial infection. And this secondary bacterial infection can happen if the patient is repeatedly scratching his ear because of the itching sensation he's feeling. He can introduce bacterial infection on top of the fungus. So for the lines of treatment, we need to do two main things. First of them is to clear the fungal debris out of the ear canal. This can be done by instrumentation using mopping or by curette, or by suction. And suction, as we see here in this picture, it has to be done under vision, or by ear wash. When we do ear wash, we may have to dry the ear thoroughly to help prevent recurrence because, again, water is a predisposing factor for fungal growth. The second line of treatment is topical antifungal preparation. The antifungal preparation, we are using typically clotrimazole drops, or we are doing ear pack with Castellani paint, or we are applying boric acid 4% drops. For the viral exotitis, they are not that common. One of them is the bullous myringitis. Here in this disease, it typically happens after upper respiratory infections. The patient comes complaining of intense pain. Clinically, when we examine the patient, we see vesicles growing on the outer surface of the tympanic membrane. This condition is self-limiting. It can recover on its own within 4 or 5 days. So what we have to do during this period is to give the patient good analgesia for the pain. For some patients, we give topical antibiotic ear drops to help prevent secondary bacterial infection. The other type of viral disease involving the external ear, of course, is Ramsay-Hunt syndrome. It involves facial nerve paralysis, And in this syndrome, the patient can develop vesicles in the skin of the concha, the part of the auricle behind the external auditory canal. This topic is covered in more details with the facial nerve paralysis. Non-infectious external otitis, they can happen in patients who are developing repeated eczema or seborrheic dermatitis. Of course, this topic is covered more thoroughly in the dermatology curriculum. For tumors of the external ear, there are benign and malignant tumors. Benign swellings are mainly of bony origin. There can be solitary swelling, what we call osteoma, or multiple swellings, what we call exostosis. Multiple swellings are common in people who are exposed to repeated exposure to cold water into their ear, and typically we call it surfer's ear for people who are doing windsurfing or wave surfing. So they are exposed to cold water repeatedly. That's why they are more prone to develop such conditions. So when do we treat bony swellings of the external auditory canal? If the swelling is small and not causing obstruction of the canal, not causing any problems, we just observe it and ask the patient for serial follow-up maybe every few months. But if the swelling is big enough to cause obstruction of the canal, causing hearing loss, or if it's retaining the debris in the canal, causing repeated external otitis, then the principle of the treatment will be to remove the swelling while preserving the overlying skin. So we need to dissect the skin of the swelling and then drill out this bony swelling. For malignant tumors of the external ear, most of them are of skin nature. As we see here, we have two types. This one in the upper part of the auricle is a rodent ulcer, a basal cell carcinoma. As we know from the pathology, it is a locally invasive malignancy that is treated by excision with a good safety margin. The other type that is more dangerous is a squamous cell carcinoma. It can develop in the auricle or external auditory canal, and this can invade to the bone of the skull base, and it can spread to the parotid, to the facial nerve. It can send lymphatic metastasis, and late it can send blood secondaries. So how do we diagnose such condition? If there is a lesion in the ear canal, okay, this is the first presentation. The patient may just come with a lesion in the ear canal. If he is scratching this lesion, it can become secondarily infected or bleed. So he can come with pain. He can come with cervical lymph node secondaries, evidence of local spread to the parotid, to the temporomandibular joint, to the facial nerve. So he can come with cranial nerve involvement. Of course, if it spreads to the ear, there will be associated hearing loss. So what we do, we need to do biopsy of this skin lesion. As we saw it in the picture, this one from the floor of the ear canal, it looks like the lesion of the malignant external otitis. That's why we need to do the biopsy to differentiate between this and that. Biopsy is important for the diagnosis, and imaging is very, very important to evaluate for the extent of the treatment. The lines of treatment, they vary according to the pathology of the lesion and to the extent of the treatment. If the lesion is really extensive, so extensive surgical resection is needed. If it's squamous cell carcinoma, an egg dissection is needed together to clear the lymph node secondaries, and radiotherapy needs to be done to help prevent recurrence, and of course reconstruction of the defect resulting from the excision of the lesion and the auricle. Some miscellaneous conditions may develop in the ear. One common condition is the auricular keloids. It happens in patients who apply piercing through their ear canal or through their auricle. So if a piercing is going through the auricle, it can lead to formation of auricular keloid. It can happen as a result of regular wounds or of surgical trauma. If the patient had any surgery to the auricle, then he can develop keloid. The keloid, as we know, it's excessive formation of fibrous tissue at the site of wound healing. So for the treatment, it's not a straightforward excision of the lesion, because again, surgical excision can lead to formation of more keloid. So this may need to be preceded by steroid injection, and continued after the excision. Steroid injection can help prevent recurrence. One of the most common conditions the patient presents with for the external ear is impacted wax. Again, what is wax? As we know, wax is a secretion from the ceruminous gland and the sebaceous gland in the ear canal. It has many known functions. It is protective because it helps to catch the debris or dust particles in the air. Another proposed function is it has an antibacterial effect. Some literature proposes that it can also have some smell that repels insects. It has acidic pH, again, that helps prevent infection. So when does the wax cause problems? The wax typically is there in the ear canal. It is secreted and it is expelled by movements of the temporomandibular joint. So typically it's causing no problems, but for some people the wax causes problems when it is impacted and it is obstructing the lumen of the external auditory canal. So it causes problems only when it causes obstruction, complete obstruction of the lumen of the external auditory canal. That's why when we ask about a cause of conductive hearing loss, or what is the most common cause of conductive hearing loss in adults, we say it's wax impaction, not only the presence of wax. So how does it look? It looks in various shapes and consistencies, in various colors and consistencies. The wax can vary in color from pale yellow up till very dark brown. It can seem like black. And the consistency can be from semi-fluid up till stony hard wax. So what the patient complains of is hearing loss, and typically the patient complains as if this hearing loss had an acute onset. He says, I was fine in the morning, but then I took a shower, or I was trying to manipulate my ear, and then it became blocked because the wax was there. It was blocking the ear canal nearly completely, but then with a few drops of water or with manipulation, this near complete obstruction became complete, so it caused the hearing loss. So what do? We need to take out the wax. This is how we treat the impacted wax. It can be done either by instrumentation. You remove it with a curette or with a hook or with a probe with a cotton. Second thing is to do suction of the wax, and third thing is to do ear wash. As we said earlier, ear wash has to come around the wax and reach to the medial end and come out. So if you need to do ear wash for the wax has to be soft, because if the wax is impacted and it's hard in consistency, the water cannot go around it, so it cannot take it out. It will simply cause it to be pushed further medially or to swell further and causing more irritation to the patient. So if we are planning for ear wash or suction of the wax, and if the wax is really hard, then we need to give wax softening drops for a couple of days, maybe 3-4 times per day for 3 to 5 days, and for these the wax, and after this the wax will be soft enough that we can remove it by ear wash or by suction. Typically the wax softening drops are oily drops, so typically people were using olive oil or hydrogen peroxide or glycerine, and now the commercially available drops are containing these materials alone or in mixtures. So we use the wax drops for a few days, and then we ask the patient to come back where we can remove the wax by suction or by ear wash. And we have to remember again that the impacted wax is the most common cause of conductive hearing loss in adults. I thank you very much for your attention.